Welcome to today's webinar, Cost Savings and Care Innovations for Prisoner Healthcare, brought to you by NCSL. All lines have been placed on a listen-only mode to provide favorable sound quality during today's presentation. It is now my pleasure to turn the floor over to Melissa Hanson. Ma'am, the floor is yours.
Good afternoon, everyone. I'm Melissa Hanson, a program principal with the NCSL Health Program, and on behalf of the National Conference of State Legislatures, I would like to welcome all of you to today's webinar, Cost Savings and Care Innovations for Prisoner Health Care. I apologize for any inconvenience some of you might have had logging on. We worked out the glitch, and so I'm hoping that we'll get started right away and you will still have a positive webinar experience. Today's webinar is supported by the Pew Charitable Trusts. We would like to thank Pew for its continued support of NCSL's work related to Medicaid cost containment. Before we get started with today's panel, I would like to remind participants that NCSL is a bipartisan membership organization of state legislatures. NCSL advocates for the interest of states and provides policymakers the opportunity to exchange ideas. This webinar is a platform for information exchange. We encourage a robust Q&A at the conclusion of the presentations and remind listeners that opinions expressed on today's webinar do not represent NCSL's policies. Also, today's webinar will be available on NCSL's website as a video archive. Now I have the great privilege of introducing our three panelists. We are very fortunate to have Matt McCullough, a Senior Associate for the State Health Care Spending Project at the Pew Charitable Trust, start our discussion. Matt coordinates the project's research on cost containment approaches, including efforts to combat Medicaid fraud and abuse and prisoner health care. Previously, he worked on Pew studies of state pension and retiree health care benefits and budget challenges during and after the Great Recession. Next, we will hear from Dr. Owen Murray of the University of Texas. Dr. Murray oversees the medical, mental, and dental services for more than 120,000 offenders within the Texas Department of Criminal Justice. Dr. Murray graduated from the Chicago College of Osteopathic Medicine. He has worked as a physician in the Cook County Jail System and the Illinois Department of Corrections until he was recruited by the University of Texas. Aaron Edwards, Senior Fiscal Policy Analyst in the Legislative Analyst Office for the State of California, will close our presentations today. Mr. Edward is responsible for providing nonpartisan and objective advice to members of the California Legislature on budget and policy issues related to correctional health and inmate and parolee rehabilitation programs. Aaron's recent publications include reports on maximizing federal Medicaid reimbursement for inmate and parolee health care. Prior to joining the state, he worked as a senior researcher for the Drug Policy Alliance and as a data analyst for Google. Before I turn the floor over to Mr. McCullough, I would like to remind the audience that the webinar today will conclude with a question and answer session. Please note that you will not be identified when you ask a question, nor can other participants see what you have typed. As a reminder, you may participate by clicking on the Q&A button at the bottom right corner of your screen and typing the question. We have plenty of time for Q&A, so we encourage you to ask questions. We will also post a PowerPoint presentation on the NCSL website with an audio archive of the webinar. This archive will be ready in 5 to 10 business days. Now I'd like to turn the floor over to Matt.
Thanks, Melissa, and thanks to NCSL for hosting this webinar. I'm looking forward to hearing from Dr. Murray and Mr. Edwards in a little while. As Melissa said, our project's research is intended to provide a cohesive picture of states' healthcare spending and how it has changed over time. State leaders know, of course, that healthcare spending overall is increasing and that it accounts for a substantial portion of their budgets each year. But it's difficult to grasp the whole picture because states' healthcare dollars come from several sources and flow out through an array of departments and programs. Many state programs are funded by dollars from more than one state or federal agency. With the report we're discussing today, and several others to follow, policymakers will gain a better understanding of what's driving costs in the specific healthcare areas. We're looking at policies and practices across the states to show lawmakers how they might better control healthcare costs while maintaining or improving health outcomes. Healthcare for prisoners is an important part of this picture. Healthcare and corrections have been two of the fastest growing areas in state budgets, so we wanted to study what's happening at the point where they intersect. How states manage healthcare in prisons affects not only inmates' well-being, but also public safety and taxpayers' total corrections bill. For instance, research has shown that the effective care and treatment for substance abuse and mental illness can reduce the likelihood that inmates will return to prison for new crimes or parole violations. What we did first was look at how much states spend on prison healthcare. It's important to note that our objective was to examine the overall trend in spending and the extent of the changes. Our analysis does not assess each state's return on its investment or the reasons why one state's spending might be higher or lower than a neighboring state. The data used in our spending analysis were published in late 2012 by the Bureau of Justice Statistics. The Bureau collected correctional healthcare costs from 44 states for 2 different years, 2001 and 2008. This is the most recent data available that covers almost all states. After adjusting the spending data for inflation, we found that most states experienced a sharp rise in spending on prisoners' health care between 2001 and 2008. In 42 of the 44 states surveyed, prison health care spending increased with median growth of 52% over the 7-year period we studied. A dozen states saw their inmate health care bills grow 90% or more over the 7-year time period. We saw these trends in states of all sizes and regions of the country. Prison healthcare spending jumped by 100% or more in states as different as California, New Hampshire, Utah, and Arkansas. And healthcare spending per inmate went up in 35 of the 44 states, by a median increase of 32%. Next, we looked at factors driving these increases, and we found 3 major reasons for higher prison healthcare costs. One was the rise in prison populations nationally. From 2001 to 2008, the number of sentenced prisoners increased by 15%. This rise was part of a multi-decade trend wherein the number of Americans in prison increased by 677% from 1971 to 2011. But the sheer number of state prisoners does not explain all of the increased spending. Higher per inmate expenses suggest that other factors are also pushing up costs. The second factor was the rapidly growing number of older inmates who tend to require more health care than younger ones. From 2001 to 2008, the number of state and federal prisoners aged 55 or older increased 94%, compared to 12% growth in inmates younger than 55. And this trend continued in later years. Like older Americans outside prison, elderly inmates are more likely to have chronic medical and mental illnesses. Caring for these individuals often requires expensive treatments, specialized correctional facilities, and additional training for prison staff. And the last factor was the rise in healthcare prices nationwide for items such as prescription drugs and medical supplies that prisons have to buy. Corrections departments and prisons are not immune to the price trend in these items that has affected all of us. Beyond these cost drivers, there are additional common characteristics of prison that can hinder the delivery of healthcare and elevate costs. These include the prevalence of mental illness, substance abuse, and infectious and chronic diseases, as well as the remote location of some prisoners and their distance from medical providers, which can lead to higher guarding and transportation expenses. All of these factors are straining state budgets. In response, corrections officials are exploring ways to rein in healthcare spending without sacrificing either the quality of care or public safety. The final piece of our research was an exploration of such strategies that address these escalating healthcare costs. To inform our review of the policy options, we interviewed correctional healthcare experts across the country, including the 2 other speakers on this webinar. Our report looks at 4 strategies that were cited frequently in these interviews and that some states credit with contributing to improvements in their prison healthcare systems. 2 things were clear from these interviews. One is that states are finding innovative ways to control prison healthcare costs and at the same time ensuring good quality care for inmates and protecting public safety. The second observation is that there is no one-size-fits-all solution to states' prison healthcare challenges. We are not recommending or endorsing these strategies. We urge corrections officials and lawmakers in each state to ask, have we considered these approaches? Could they help us? I'll give a couple state examples to illustrate each strategy's potential benefits. But before I do, it's important to note that states' cost containment options are impacted by their legal obligation to preserve healthcare quality. The U.S. Supreme Court has held that prisoners have a constitutional right to adequate medical attention and concluded that the Eighth Amendment is violated when corrections officials display deliberate indifference to an inmate's medical needs. This obligation also applies to private medical contractors. So this is the legal standard that any strategy must meet. The first of the four strategies is the strategic use of telehealth. More than half of the states have used telehealth technologies in prisons. Video conferencing between an off-site doctor and an incarcerated offender is a common application of telehealth in correctional settings. Exam cameras, monitors, and electronic stethoscopes allow doctors to capture vital signs and treat patients remotely while nurses or physician assistants at the correctional facilities operate equipment and provide support. The technology's greatest cost-cutting benefit lies in bridging the distance between prisons and medical professionals. By allowing inmates to consult with primary care physicians and specialists without leaving prison grounds, telehealth eliminates transportation and guarding expenses and can reduce the time needed to determine a diagnosis and begin treatment. There can be public safety benefits, too, because inmates likely need fewer trips off prison grounds for medical care. Texas, as Dr. Murray will speak to next, has made extensive use of telehealth in prisons, and research suggests that this strategy has produced better health outcomes for its prisoners and significant savings for taxpayers. One study found that telehealth, combined with other measures, contributed to lower average blood sugar rates for diabetic inmates and an 84% reduction in AIDS-related deaths. Another study estimated that telehealth saved Texas $780 million between 1994 and 2008. The second strategy discussed in our report is outsourcing the provision of prison health care services. Many states have looked to outside providers to provide all or part of their prison health care services at lower costs while maintaining or improving the quality of care that inmates receive. Effective management and oversight is critical to every service government provides, and that applies to prison health care too. Beyond deciding whether to outsource services, policymakers and corrections officials need to consider how they will ensure that contractors meet state goals for quality and cost. Our research shows that some states have managed the performance of their contractors quite effectively, and these states have evidence that their diligence has paid off. For example, New Jersey has delivered improved care for inmates while controlling the state's costs through an outsourcing partnership with University Correctional Healthcare, which is based in Rutgers University. All medical and dental care for about 24,000 inmates has been provided through this partnership since 2008. New Jersey officials report improved health outcomes for prisoners with hypertension and HIV and a 42% reduction in inmates' medical complaints. Meanwhile, the state's prison health care expenses were $10 million below the budgeted amount in 2008 and have remained mostly flat since. A third strategy we examined is the use of Medicaid to finance certain health care services for inmates. This practice is innovative, and the implementation of the Affordable Care Act could amplify its impact in certain states. A number of states have made a concerted effort to enroll eligible prisoners in Medicaid and build a program for qualifying health services. The qualifying services are fairly limited, though, specifically only care delivered outside of prison. For example, when a prisoner is admitted to a hospital or nursing home for more than 24 hours. Medicaid does not cover health care delivered inside prison walls. Mississippi, Nebraska, New York, and Washington State are among the states that have explored Medicaid financing for eligible prisoners' inpatient health care costs. The potential benefits are twofold. First, the state can obtain federal Medicaid reimbursements that cover at least 50% of enrolled prisoners' inpatient hospitalization costs. Second, the state may save additional dollars because Medicaid's payment rates for healthcare providers are typically the lowest of any payer in a state. Mississippi launched its Medicaid financing initiative in 2009 and reports savings of about $6 million annually. Those are significant savings considering that the state's total bill for prison health care was roughly $50 million in 2008. The states that expand their Medicaid eligibility under the Affordable Care Act may reap the largest savings from this strategy. This is because most inmates are non-disabled adults without dependent children, a group generally not eligible for Medicaid today. Many of these inmates will become eligible for Medicaid in states that expand eligibility under the federal health reform law. But while many more inmates will be eligible for Medicaid under the ACA, Medicaid will still only cover off-site inpatient health care costs because Medicaid does not and will not, even under the ACA, cover health care delivered inside prison walls. The key to remember about this strategy, though, is that off-site inpatient health services can be quite expensive, and so having them covered under Medicaid can bring substantial savings to a state. Moreover, the newly eligible prisoners under the ACA will be eligible for the enhanced federal match. Researchers looking at Ohio's potential Medicaid expansion estimated that the state's corrections system would save a total of $273 million from 2014 to 2022. Aaron will speak to California's experience in depth in a little while, but I'll just say that recent projections from his office suggest that it stands to save nearly $700 million annually after 2014 due to Medicaid expansion. The fourth and final strategy is the use of medical or geriatric parole. As I said earlier, America's incarcerated population is growing older and therefore sicker and more expensive to care for. In response, states have adopted such policies that allow for the release of elderly, terminally ill, or incapacitated inmates who meet strict eligibility criteria. By paroling offenders who qualify, states eliminate the need for expensive, round-the-clock guarding and frequent transportation services for them. Even if the state is responsible for some of a parolee's health care upon release, the state's share of the cost would be reduced if a parolee is eligible for a program such as Medicaid. But our research shows that relatively few prisoners have been released so far under medical or geriatric parole policies. Three important reasons for this are the narrow or hard-to-implement eligibility criteria states have set, the lack of nursing home space for incapacitated offenders, and opposition to this practice among lawmakers and citizens.
Exactly.
But some states have met these challenges and preserved public safety at the same time. For example, from 2010 to 2012, California granted medical parole to 47 inmates, reducing its correctional health care expenses by more than $20 million. In 2011, Louisiana expanded parole eligibility for elderly prisoners. Nonviolent inmates who are at least 60 years old have served more than 10 years and have been designated as low risk by the Department of Public Safety and Corrections, among other requirements, may apply for parole consideration. Ohio also passed geriatric parole legislation in 2011 as part of a larger package of criminal justice reforms projected to save the state $463 million over 3 years. A measure of the package that permits the Ohio Department of Rehabilitation and Correction to petition for judicial release of certain inmates who have served 80% of their sentences, among other requirements, was expected to account for a sizable portion of the savings. New York expanded the eligibility requirements of its medical parole policy in 2009 to include any inmate who is judged not to be a threat to society, is chronically or terminally ill, is physically or cognitively incapacitated, and has served at least half of his or her sentence. Those convicted of first-degree murder are ineligible. The state expected the expansion to save $2 million annually. So to sum up, growing prison health care bills are an important challenge for corrections officials and lawmakers. In response, many states are seeking more effective and affordable strategies for providing inmate health care. There is no single solution. but several states have achieved savings in ways that protect or even enhance inmate health and public safety. State leaders can learn a great deal from the experience of these states as they consider ways to improve the return they're getting for prison health care dollars. That concludes my presentation. I'd like to thank NCSL again, and I encourage everyone listening to visit our website at www.pewstates.org/healthcare spending, all one word, where you can find this report as well as our other research. For any questions or feedback listeners would like to provide offline, my contact information is available on this last slide. I can be reached directly at 202-540-6398, and my email address is mmckillop@pewtrusts, with an S at the end of it, .org. Thank you very much, and I'll now pass this along to Dr. Murray.
Thank you, Matt. Appreciate the opportunity to be on the call today. I was asked if I would just kind of briefly summarize our approach down here in the state of Texas. And so as we move to the first slide, I thought I would just kind of give an overview of what UTMB correctional managed care looks like. As most of you know, we were a legislatively created partnership that occurred in 1994. The partnership exists between the University of Texas Medical Branch, Texas Tech University, and the Texas Department of Criminal Justice. From UTMB's perspective, we employ about 3,000 total healthcare workers. We're responsible for approximately 120 of the 155,000 offenders here in the state of Texas. We provide services at 83 facilities. We are truly a cradle-to-grave system. We did a little under 200 births last year and had just over 400 deaths. We provide full medical, dental, and psychiatric services to all of the offenders that we're responsible for. We operate 2 inpatient medical facilities, one in Huntsville and one a little closer to Galveston here in Texas City. We have about a total of 450 infirmary beds, which, given what Matt talked about in terms of the increasing number of 55 and older, as well as just the impact of hepatitis C, HIV, end-stage liver disease, chronic renal disease, the number of those beds are really becoming a premium, not only in our state, but in all states. And as they look forward, I think decision makers are going to have to look at how do we build prisons in the future that are going to be able to accommodate this level of acuity. We also operate 2 mental health units, 500 beds apiece. We do dialysis, and we operate our own dialysis center. We don't contract out for those services. We've found that through hiring our own nephrologist and having our own staff take care of those patients, we better get a better quality product at a better price. We run our infectious disease program through our telemedicine system. We have an infectious disease doc who has some other providers under her structure that provide all the HIV and hepatitis C care throughout the state. It allows us to remain very consistent with our disease management guidelines and our formulary, and it provides a very consistent level of care to all patients that have those disease process. Geriatric program, which is obviously ever growing. We just went over 10% of our population, so we have a little over 15,000 patients over the age of 55 in Texas. And then we have, for our special needs population, assisted disability programs. We run our own medical transportation that historically used to be 911 calls, but over time that just became less fruitful. We've taken those ambulances and converted into multi-patient vehicles that can take anywhere from 6 to 12 offenders at a time to scheduled medical appointments. Since we do all of our planned hospital and subspecialty care in Galveston, it makes it very convenient for us to provide a level of transportation that really is more in line with the clinical condition of some of our offenders who are fairly frail or have some limitations. Those trucks allow us to not have to use free world ambulances and be able to use less security as we move people through the state. We have an electronic medical record system and telemedicine program that I'll talk a little bit more about, but we've been operating those for at least the last dozen years, and we have obviously radiology out in our facilities. The two big programs that are fairly unique to Texas is, number one, our pharmacy. We have a pharmacy up in Huntsville. We buy our own drugs. We package our own drugs into blister packs, and then based on an electronic ordering entry system, we ship drugs to all the facilities, not only ours, but Texas Tech as well. And then we also provide care for the Youth Commission, and we provide pharmaceutical services for them as well. And then Hospital Galveston, which is a unique structure in itself. It's a 120-bed, 8th-floor tertiary care hospital with subspecialty clinics. It's a maximum security building, staffed and run by PDCJ, and it really is unique and allows us to do some different things in terms of our subspecialty care provision that a lot of states struggle with, just given they have smaller populations and don't have a structure like that. And then we have a free world hospital network trying to take care of the emergent conditions that come out at our facilities. We have a free world hospital relationship with hospitals close by to our facilities. And 2 years ago, the legislature mandated Medicare rates for those, so that's what we pay those facilities. Next slide just kind of looks at, and this is just UTMB's revenue expense from FY04 through 13. As you can see, it differs a little bit from what you've seen on some other slides, but that's because you have to incorporate Texas Tech's per member per day, which gets you closer to our current FY13 rate. But we've done a fairly good job, despite the economics in the state and the rising cost of care in terms of pharmaceuticals and acuity, to maintain a fairly consistent product at a fairly consistent price. On slide 4, you see this is kind of our keys to success, and I'll go through each one of these. Our state commitment to a model of care, Hospital Galveston, as I alluded to earlier, 340B pricing, which UTMB uniquely adds to the contract, our strategic technology investments, and then our dedicated staff. So on slide 5, our commitment to a model of care. In the intro it said that I came from Illinois, and I did. I spent 3 years. Actually, I started at the county jail and then spent 3 years in the Illinois Department of Corrections. And over that 3 years, I worked for 4 different healthcare providers, and quickly realized that that was not going to be a path for me to find either security in retirement or any kind of career growth. And so I moved down to Texas and have been here for the last 19 years. And I think that commitment to a model of care is really exceedingly important, especially for the staff, because ultimately it is the healthcare staff that runs the program. And your ability to attract and retain healthcare workers in this hyper-competitive market in which we exist truly is a challenge. And it's not always offering benefits and offering, the best pay. Certainly those things help. But being able to reassure people that they're going to have a job, that they can grow their career within your healthcare system is exceedingly important. From a legislative perspective, committing to this model really has improved our dialogue with the legislature. Instead of worrying about what model we're going to next, we really focus on what are our current issues right now, whether it's staffing, whether it's new changes in care. The legislature understands our vocabulary. We have, I think, a better continuity of issues and discussions around those issues. And I really do think that it has helped both sides, us kind of understand the funding source and difficulties, as well as the understanding from their perspective, the things we need to continue to deliver a quality product that's going to meet our patients' needs. And then the last thing is that, committing to a model of care for the last 20 years, it's one of the reasons why we have an EMR, why we have telemedicine. We have taken all of the resources available to and for prison health care and invested them back into our current system. And so, again, I think committing to a model of care has truly been one of the key fundamental reasons why we have been able to be successful here in the state of Texas. On the next slide, Hospital Galveston. As I said, having this facility here really does help to manage, I think, it is a difficult or a hard to manage cost for many states. Once you get care outside the prison and you get it in the hands of other subspecialists, it becomes a little bit more of a challenge to manage that care, both from a clinical perspective and a cost perspective. Since we do all of our hospital urgent and emergent or planned hospital care, as well as all of our subspecialty care in one building, we can utilize trained subspecialists to understand both our prison population, also understand our level of funding, and what's the best ways for us to balance that care. The other thing, because we bring all patients here, is that our level of care in terms of whether it's orthopedic care or cardiology care is 100% consistent. And it's a challenge when you're out in big states, finding certain subspecialty resources, but also getting a consistent level of that subspecialty resource. So I don't have a different level of care in the north than I do from the south. We don't have that issue here in the state because all of our subspecialty care is done through one facility with trained subspecialty providers. It's really reduced our risk globally within the system, and our litigation associated with subspecialty care is virtually nothing and has been that way for the last decade. So it certainly has been a benefit to have one referral center for all of our subspecialty care and all of our planned hospital care. Regarding 340B pricing, UTMB is the qualifying entity here in the state. It is certainly something unique to the state of Texas in terms of our ability to get that pricing. We only provide it to the UTMB patients. It is not something that Texas Tech can access. But we have what you need to be able to get 340B is you need to have a disproportionate share hospital, which we do. You have to employ the prescribers, which we do. And then we have to manage the medical record, which we do as a custodian for TDCJ. In FY12, the savings was about $50 million, and given where we see hepatitis C treatment going and the cost of that particular care, we would anticipate, though, that savings to grow significantly over the next biennium. On the next slide, you can see just FY10, 11, and 12, kind of where those 340B savings have come from and where they're going. And as I said, I think as you look into the next biennium, we're going to see even more significant savings from this program. So it's certainly a benefit that the university brings to the state of Texas. Our strategic technology, Matt talked a little bit about it. Certainly telemedicine has been one of the keys to our success. When we originally rolled out telemedicine, it was going to be a subspecialty vehicle with which we would provide care, not having to bring as many people down to Hospital Galveston. And we did about 100,000 encounters last year. About 25,000 of those were subspecialty encounters. But the bulk of our telemedicine program is now primary care and primary care mental health encounters. Given the struggles that we have in certain geographic areas to find providers, this is an outstanding way for us to still be able to provide access to primary care, medical, and mental health services despite having challenges in staffing. We've opened up 3 hubs, one in Houston, one in Austin, one near Dallas, where we have free-rolled office space. We hire physicians not into a prison but into that office, and they are able to see patients throughout the state. The people that the docs we hire in are from our system. They're trained in corrections. They know the system. They know our formulary. They know our referral process. And so we're able to maximize their skills and their experience by doing telemedicine. And as I said, it has really helped us provide access and timely care throughout the state. And then the EMR, everyone is obviously making a move towards the EMR. The EMR is certainly a way for us to do our day-to-day transactional business, but it's also a way for us to incorporate in a meaningful way quality and change to process using that tool to, again, kind of shrink the cracks that unfortunately offenders fall into, given their movement around the system, given their tendency towards noncompliance and not showing up for appointments. The EMR and its quality processes really give us a way to ensure that we're doing the best we can to provide the highest level of care despite an offender's lack of interest in participating in that plan. And then at pharmacy systems, we have order entry throughout the state. We have disease management guidelines, and we have a very strict formulary that we follow. We're about 98% generic, which really does help keep our costs down. And then the last slide, as I said, it is ultimately the staff that dictates and is your program. If you can't get them, you don't have a program. And so since inception, our FTE count has dropped by about a third. We have the lowest staff per offender ratio in the nation. I'm not sure if that's something we're supposed to be proud of or not, but it is what it is, and we've made do. We've been able to maintain our ACA accreditation at all our facilities. Through the EMR, we've been able to document our clinical outcomes, and we are really doing a very good job with those patients who have known chronic disease, hypertension, asthmatics, diabetics, patients with HIV. And again, given that commitment to our model, our ongoing conversations with the legislature about our needs, whether it relates to staffing, whether it relates to expanded levels of care for geriatric and end-stage liver disease patients, we certainly have set the stage, I think, by producing a good product that we can go to them and have meaningful conversations. And then the last slide just kind of, again, looks at our FY12 data and kind of shows where Texas falls out in terms of our per member per day cost. And with that, I'll be glad to turn the microphone over to Aaron.
Great. Thank you, Dr. Murray, and thanks to NCSL for organizing this webinar today and giving me a chance to speak to you all. I'm going to be talking in a little bit more depth about an issue that Matt touched on earlier, which is how states can obtain federal funds for inmate medical care. Just a quick note about our office. I'm with the Legislative Analyst Office here in California. We're a nonpartisan office, and we provide objective, data-driven advice to the members of our state legislature here. So let me just say at the outset here, I'm suffering from some pretty bad allergies at the moment, so I'm a bit of a coughing, sneezing mess, and I apologize if that interrupts my presentation at any point. Just be glad you're not subjected to it in the same room as I'm in right now. Just a quick overview of what I'm going to be talking about. First, I'm going to give a little background on California's prison medical care program, just for some context, and for those who aren't familiar, just a real high-level overview of how Medicaid works. And then I will be talking about how some new changes in federal and state healthcare policy in California, specifically the Affordable Care Act, have created some new opportunities for savings on prison medical care. And then finally, I'll just finish off by giving an update on what we've been doing here in California to take advantage of the opportunities created by the Affordable Care Act. So just by way of background, it's important to note that California is unique in terms of our being under a federal receivership for our inmate medical care program, and that's related to some litigation going back to 2001, which found the state was not providing a constitutional level of medical care. And so since 2006, we've been under a federal court-appointed receiver. And what that means is basically the receiver manages the day-to-day operations of the prison medical program. Now, most of the care delivered by the receiver is delivered by state staff in state prisons, but there are circumstances that require inmates to be referred outside of the prison to off-site hospitals to receive usually complicated surgical procedures that prison staff lack the expertise or the resources to be able to deliver within the prison walls. So in 2011-12, the receiver spent about $260 million on such contract costs, and that includes almost $110 million for costs that were for inpatient care. And the reason that's significant is will become clear, if it's not already, when I talk a little bit about how Medicaid works and when inmates are eligible. So just a really high-level overview. Medicaid is a joint federal-state program, and it provides health insurance to certain low-income populations. And in California, our Medicaid program is administered by the Department of Health Care Services, and it's known as Medi-Cal. So in choosing to operate a Medicaid program, states receive federal funding for a significant share of the program costs, and that share varies by state. In California, it's currently 50%, so we basically receive $1 from the federal government for every dollar that the state spends on that program. Eligibility requirements also vary by state, and right now in California, the eligibility requirements are that an individual has to be low income and they have to fall into certain categories. So typically that would be individuals that have dependent children or are blind or pregnant or over 65 years of age or under 19 years of age or have some type of disability. Individuals who aren't lawfully residing in the United States are generally ineligible for Medicaid, and low-income childless adults are also generally ineligible. So let me talk a little bit about where the Medicaid world collides with the correctional healthcare world. So as Matt mentioned earlier, federal law generally prohibits the use of federal Medicaid funds for inmate care. However, there's an important exception, and that is if an inmate is receiving care in an off-site hospital and that care lasts more than 24 hours, it's considered inpatient care. And if that inmate is otherwise eligible for and enrolled into Medicaid, then Medicaid funding can be used to pay for that care. So most inmates fall into the category of low-income childless adults who are currently ineligible for Medicaid. So historically, the number of inmates eligible for receiving the federal Medicaid funding has been limited to the relatively small number who are pregnant and elderly and blind and disabled. However, the real game changer here comes with the Affordable Care Act, and that the game changer is really that the ACA allows states to expand their Medicaid programs to populations, particularly low-income childless adults, that formerly were not eligible for coverage. And so California has exercised the authority to undertake this expansion beginning in 2014. And it's also important to note that the federal government, as a sort of sweetener to encourage states to undertake the expansion, is going to pick up 100% of the cost for newly eligible Medicaid beneficiaries in 2014 and for the first 3 years, and then that'll eventually step down to 90%. In California, we also have what's called a low-income health plan, which just real briefly is kind of a temporary coverage program that's supposed to be a bridge to 2014, and it's a county-operated program which basically extends the health care coverage to low-income adults, and the counties pick up the non-federal share of costs right now for that program. The upshot of all of this is that ACA has really created some very significant opportunities for prison medical care savings. The majority of the number of Medicaid eligible inmates is going to increase significantly in 2014. So we're estimating that in California, roughly 70% of our inmates will in fact be Medicaid eligible when the expansion takes place in 2014. The remaining 30% mainly are individuals who are not residing lawfully in the U.S. and who lack valid Social Security numbers. We have a high proportion of those folks in California. In other states, it will probably be significantly lower. But other than those individuals, almost all inmates will be eligible based on their low income. Now, in addition to having an increase in the number of eligible inmates, we're estimating that most of the inmates will be newly eligible and thus will qualify for that 100% federal match. So we're anticipating probably about 80% of those eligible in 2014 in California are going to be newly eligible, and so we'll have that 100% federal match for their off-site inpatient care. So we're projecting some pretty significant potential savings to the state general fund. And just to give you an idea of what the magnitude is here, this chart on this slide shows our current projections, and obviously this will vary by state, and since California spends so much to begin with on care, our savings are going to be higher than most other states. But if you look at the first full year of Medicaid, the Medicaid expansion in 2014-15, we're projecting almost $70 million in annual savings from increased reimbursements from the federal government. So very significant savings. Now, how do we achieve these savings? Well, that's really the million-dollar question. In our case, really the $70 million question. It's a somewhat complicated process. I'll give you kind of a high-level overview of the system we've set up here in California. Basically, and I should say that the text is kind of small on this slide. It is in our report that I'll refer to later, so if you want a more clear version of this, you can refer to our report. Basically, the way the system works is that an inmate will receive off-site inpatient care, and the federal receiver will pay for the cost of that care in full after that care is delivered, and they pay that cost at whatever the pre-negotiated contract rate is with our outside providers. And typically in California, we pay higher than Medicaid rates for that care. And I'll explain later how we deal with that when we get the reimbursements. But the first step is the inmate receives the care, and the receiver pays for the care, and then the receiver goes ahead. There's about 8 staff who are charged with looking at whether or not that inmate, based on their demographics, likely qualifies for Medi-Cal or the low-income health plan. If they appear to, and most would, again, because they're mostly low-income, the receiver staff then submit an application to our Department of Healthcare Services, which takes us to the next step, which is the DHCS reviews that application and determines if the inmate is eligible for either Medi-Cal or the low-income health plan. Now, the third step here under enrollment, well, this is our current process. It's going to be somewhat more simple in 2014 because the low-income health plan will go away and all those beneficiaries will be rolled into Medi-Cal. So really the path on the left is the path that everyone who's eligible will take, which is FDHCS determines the inmate is eligible for Medi-Cal. They'll go ahead and enroll them into the Medi-Cal system. And then that takes us to the next step, which is the actual claiming for those services. So the receiver will go ahead and submit a claim to the Department of Healthcare Services for the cost of the inpatient services that have been rendered. And at that point, DHCS just goes ahead and ensures that expenditures are allowable under Medicaid. And then the final step then is that DHCS will obtain that federal match and then authorize the reimbursement to the receiver. And as I said, we typically pay higher than Medicaid rates in California, and so whatever the state pays that's above the Medicaid rate that the federal government will reimburse, the receiver basically pays that full cost above and beyond the Medicaid rate. So that pretty much summarizes the process in a nutshell. One thing I would point out here is that we've also been able to get federal Medicaid administrative assistance funding that is available for doing eligibility determinations and enrollment for the staff that are in the receiver's office and our Department of Healthcare Services basically administering this process. So that's a 50% federal savings on the cost staff, or the staff of those cost of those staff, excuse me. So I think just kind of conclude here by saying, this isn't a really easy process to set up. It does take substantial coordination and cooperation between different agencies, which I think can be challenging. I won't suggest that this was an easy process. There's been some hurdles along the way, and there have been some technical challenges, with getting the reimbursements and the processing of these applications, but folks have been working diligently, and I think I'm very optimistic that going forward we're going to be capturing these savings. And I think, given the magnitude, you probably agree it's certainly worth the investment of time and effort for the potential savings. So that concludes the main points of my presentation here. So I'll just leave you with some resources if you're interested. There's a citation for a recent report on this subject, and in addition, another related report released in May, which looked at how the state could maximize federal reimbursements for parolee mental health care in the community. And here's my contact information. If you have any questions about all of this, feel free to reach out. I'm certainly ready and willing to assist in any way if you are interested in doing something like this in your state or have any questions about the challenges we faced here in California. And then finally, this is just a link to our website where you can access those reports I referred to. And with that, I will go ahead and hand it off to Melissa for the Q&A.
Great, thank you. And I would like to thank all of our presenters for their excellent presentations. We will now open the floor for participant question and answer. As a quick reminder, to ask a question, please click on the Q&A button and type in your question. Please make sure to ask your question to all panelists. And remember that questions will remain anonymous. We might not have time to get to everyone's questions, but I will follow up and ensure that your question is answered via email if we are not able to answer it on the webinar today. Matt, the first question is for you. Has prisoner health care cost increased more than the general health care cost for the general population? And then the second part of the question is for Dr. Murray. If so, can you explain why? Matt, will you start us off?
Sure, Melissa. So that wasn't something that we looked at specifically. Obviously, different venues or healthcare settings carry with them their own unique characteristics. So it's difficult to make comparisons like that. But I mean, I would note that all of our data were adjusted for inflation. So any percentage changes we show are all in 2008 dollars, and so if they were nominal figures, which is how sort of premium changes over time tend to be reported, they would be much higher. But as I said during my presentation, part of what is driving up costs is certainly just the higher expenses in terms of supplies and providers that corrections departments are not immune from, that other settings outside in the community have also been experiencing over the last decade or so.
Dr. Murray or Aaron, do you have anything to add to that?
I don't have anything to add.
This is Owen. I think interestingly enough, if you look at Texas, I mean, we have compared ourselves internally to some of the employee retirement and teacher retirements groups and looking at their cost of care. And, again, I think because we are, in prison, you're able to manage some of those costs. And I certainly understand, rising pharmaceutical costs, provider costs, et cetera. But I think within our field of care, we really do have the opportunity to control and manage the care that we provide. We have a different, obviously, we don't have a free world customer base. We have an offender customer base. And so although satisfaction is important, it is not a driving force behind everything we do, that we often make decisions that really do help us align our care and our costs a little bit more closely.
Great, thank you. The next question is for Aaron. Aaron, for a state that is not expanding Medicaid, do you think that accessing federal funds for inmates is a worthwhile endeavor?
I think it really depends on what the current eligibility requirements are in your state, so you probably want to take a look. Different states have different eligibility requirements, as I said, and so I know that some states are fairly restrictive, and that might mean that only a small portion of the inmate population are potentially eligible. And if that's the case, then I think you'd really have to think hard about whether it's worth the effort, because as I said, it is a fairly complex process. But if it's the case that you still have a significant number who are eligible, I think it's worth the investment, because I mean, having the feds pick up that significant, I mean, if it's 50% of the cost, those inpatient care services can be extremely expensive, and so it's potentially a very large cost saving. So it's really just a matter, I think, of looking at what the population looks like, how many of them would be eligible for Medicaid, and comparing that against what your expenditures are on inpatient care to kind of do a cost benefit and see if it's worth the effort.
Great, thank you. Dr. Murray, this question is for you. Who does UTMB bill for services, and do you own your own facilities?
Well, we correctional managed care, a department within UTMB, we get a bill from our prison hospital for those services, and we get a bill from the faculty group practice where we get our physician coverage. So we pay a bill that we receive from our hospital on campus, as we would any hospital that we do business with out in the state near our prison. So we accept those bills, and then the rest of the employees out in the facility are our UTMB employees and are paid accordingly. And then we have contracts, obviously, for pharmaceuticals and other deliverables that we use the university's purchasing power for to get some more preferential pricing.
Great, thank you. And we have time for one more question, and this is directed at all panelists, and I'll have Matt start us off. Can you talk a little bit about the importance of electronic medical records? And then if Dr. Murray or Aaron could talk about any research in terms of buying a product or developing and having the state develop their own. Matt, will you start us off?
Sure. And that was something, electronic medical records is something we looked at briefly, but wasn't sort of a primary area for our study. I would point, there's an example in our paper in Kansas, which has used electronic medical records as well as other software to be able to sort of track metrics, as Dr. Murray was talking about, in terms of the care that inmates are receiving and how timely that care is and how quickly initial sort of screening is done and preventative care. And then based on that, it uses those electronic medical records to sort of hold its private contractors accountable. So I'm sure there are other examples throughout the country where they've come into play and help preserve both the quality but also help to contain costs.
And this is Aaron. I say that in California, this is an issue that I know the receiver's office has been looking at for some years now, and they've been thinking about acquiring an electronic medical record system. We don't really have one at the moment, and we have, as I said, been looking at it for years, and initially the receiver's office was looking at building a system, hiring a contractor to really build a system around our business practices in terms of how we deliver care here in California in our prison system, and they decided that was pretty cost prohibitive at that time. And since that time, they've just sort of changed their approach, and right now they've actually just entered into a contract to get an off-the-shelf electronic medical record system, and their approach now is going to basically be to adopt some different business practices around how we deliver our care to basically adhere to the way that electronic medical record system works. And so it's lowered the cost significantly because it is an off-the-shelf system and it doesn't require much development. It's really going to be a change management project going forward in terms of changing how we deliver our care. But I think it does have promise to both increase the quality of care as well as increase the transparency and the reporting on the quality of care that we're providing. So hopefully that'll help with some of our court oversight as well.
This is Owen. All I can really add to the discussion is that, it's an inevitability. I mean, the world is moving to an electronic, health record. And so states are going to have to choose what they choose in terms of build your own or off the shelf. We went off the shelf. But ultimately, it's about integration. You have to have that record integrated, not only in what your business practices are, but in terms of how you order medications, in terms of how you order your consults, in terms of how you work with security to make sure that your medical record at your facility is up to date with the offenders who are at that facility. All of those integrations are critical, not to even mention lab and radiology. That's really what you need to plan for. Whether it's an off-the-shelf record or a build-your-own, they all can accommodate that, but you really do have to, especially on the correction side, I think have a very good understanding of what their IT infrastructure looks like and how adding an EMR will impact their ability to get their work done safely, securely, et cetera. So, it's a change for anybody. When you start it, no one likes it, but down the road, 5-10 years, people are very satisfied.
Great, thank you. Again, I would like to thank today's speakers and all the attendees for your time and participation in the webinar. Again, the webinar will be available online in 5 to 10 business days, and thank you.
Thank you. This does conclude today's teleconference. We thank you for your participation. You may disconnect your lines at this time, and have a great day.